Welcome to the VCU Department of Internal Medicine Grand Rounds. Today is a very special lecture sponsored by the Division of Endocrinology. It's the annual Blackard lecture. And in 1 second, I'll turn it over to our chair in a minute to introduce our speaker and talk a little bit about Dr. Blackard. But just real quick, a couple of housekeeping items. The CME code and the QR code for attendance will be available now and at the end of the lecture for CE credit. Also, the lecture is recorded and will be posted on the Department of Internal Medicine Grand Rounds website. Link should be active in the next week or two. If you need any technical assistance or anything, please utilize the chat function. Myself or Thomas Bryan will be able to assist you with that. So with that information, I'm going to turn it over to the chair of our Division of Endocrinology, Dr. Francesco Celli, to introduce Dr. Matthew Ringel. Thank you.
Good afternoon, everybody. It's a true honor introducing a great colleague, a great scientist, and a great friend that decided to spend some time with our division. Dr. Matt Ringel is a professor of medicine and director of the Division of Endocrinology, Diabetes and Metabolism at Ohio State. He also has a leadership role in the Ohio State Cancer Center and is co-director of the Thyroid Cancer program there. He's author more than in excess of 150 papers, and his career is stellar. He's a graduated of UVA, went to med school at University at Penn State. Then he completed his training in endocrinology. He did his residency at Georgetown, and he did his fellowship at Johns Hopkins University. And then he joined the group of Dr. Wartowski and Dr. Berman at Washington Hospital Center before moving to Ohio State, where he moved up to the rank. Dr. Ringel is a great scientist and a real clinician, which is nice to have together. And I asked him today to give us kind of a look on thyroid cancer and the multiple pathways leading to development and progression of thyroid cancer as a prism to look on personalized medicine. And I'm sure it's going to be a fantastic lecture. If there is one take-home message, I hope nobody will ever say, "Oh, if that's thyroid cancer, that's the cancer I want to have." Because when it goes sour, it goes really sour. So without further delay, Matt.
Thank you, Francesca. I appreciate it. Hopefully you can see my screen show on the, you see the correct screen? Great, thank you. So it's a really pleasure to give this lecture in honor of Dr. Blackard. I did take a look a little bit. He's a obviously renowned clinician and researcher at VCU. He was the division director and really a terrific researcher in diabetes and also in other areas in endocrinology, but mostly diabetes and lipid physiology, and really an impressive record. So it's really an honor. And it's a shame that I can't be there physically, but hopefully next time. As Francesco said, I'm going to be talking a little bit about something near and dear to my heart, which are understanding the genetic and genomic changes in thyroid cancer that lead to progressive disease, so we can improve therapeutic targeting. So first, see if I can get this to go. There we go. I have no disclosures at all. I'm the current co-chair of the American Thyroid Association Thyroid Cancer Guidelines Task Force, and I'm a current editor-in-chief of Endocrine-Related Cancer. All my funding is from the NIH. So the goals and objectives of today's talk are we want to review new data on genomics and regulators of thyroid cancer and metastatic progression. We want to discuss new molecular data regarding Hercule cell cancer, which I'll mention. And we want to really focus most of the talk on defining potential therapeutic targets for progressive disease. and translation of that into clinical care. So first, to set the stage, thyroid cancer is the most common malignancy of a classical endocrine organ. It's had a dramatic increase starting in the 1970s up until a few years ago, largely due to increased detection with the advent of ultrasound-guided FNA for small nodule detection and evaluation. That's flattened out over the past few years due to changes in guidelines. However, the number of people dying from thyroid cancer has continued to increase, even though this number is flattened. So it's clear that there are two components to this. One is a increased diagnosis of early stage thyroid cancer that may or may not require therapy. And the second is a true increase in the more aggressive disease as well for less certain reasons. Thyroid cancer is a bit of an anomaly. It is much more common in women than men as a non-reproductive organ, about 3 to 1, so it's quite substantial. And the median age of diagnosis is between 45 and 54 years. Clinical management, for the most part, is handled surgically, either hemithyroidectomy or total thyroidectomy, as we spoke about yesterday, relative to the size of the tumor. Radioiodine therapy in selected cases, TSH suppression therapy, again, in selected cases, and it's characterized by metastatic dormancy, meaning that many patients will have residual disease on the basis of thyroglobulin levels or even with small nodules in the lungs or nodes in the neck, and it may stay stable for decades. And so that's important to recognize when you're identifying patients who may or may not benefit from aggressive therapy. For those patients that do require aggressive therapy, we, as of the past 5 to 10 years, this list was 0, and now has many on the list of FDA approved inhibitors for thyroid cancer. I'm going to spend a fair amount of time showing you data on this, so I won't stress it now, but suffice it to say that none of these are curative. They got approved off of reductions of lengthening of progression-free survival. And of course, there are more targeted and immunotherapies that we'll talk about later. So thyroid cancer histology is broken up into well-differentiated, poorly differentiated, and then the very rare anaplastic thyroid cancer, and then medullary cancer. So medullary cancers of the C cells, neuroendocrine tumor associated with MEN2A in 25% of cases. We're not going to discuss that in detail today. Anaplastic thyroid cancer we'll talk about a little bit. This is incredibly aggressive. Median survival rates are about 6 months. And it's a true emergency when patients present with this disease. And then the rest of the cases is what we're going to focus on, which are well-differentiated or poorly differentiated variants of thyroid cancer, the most common of which is papillary thyroid cancer, which accounts for about 85% of all cases, and classically has a couple of different histologies. Classical or tall cell variant, which is most commonly has a BRAF V600E mutation. Classical variants with true papillae formation, mostly in young people or individuals who've had radiation exposure that have fusions in the RET gene, NTRK gene, and others. And then what's called follicular variant of papillary thyroid cancer, where the thyroid cancer cells are present because of their features, but they still maintain follicles, and those have most frequently RAS mutations. So what are the predictors of aggressive thyroid cancer behavior when you see a patient? Well, older patients, obviously patients with larger or gross local or invasion, tumors that have a lot of vascular invasion. If they present with distant metastases, particularly if they're larger or if they're bones or if they're in the bones or the brain. Again, patients that are older, 45 is probably too young here. It should be 55 because the staging changed. And also there's some data that if it's FDG avid on a PET scan, it can be associated with a worse prognosis. Obviously, poorly differentiated tumors and anaplastic cancers tend to be more aggressive than well-differentiated tumors. And then we're going to talk a little bit about genetic alterations that might predict such behavior. So this is from a paper of mine that we published a few years ago. I'm going to come back to this. When I think about thyroid cancer or any cancer for that matter, we think about multiple stages in the lifetime of a tumor, from primary tumor growth, development, to local invasion, to vascular invasion, where then it can metastasize, either grow very quickly, like an anaplastic thyroid cancer, which we would call a short dormancy, or maintain dormancy for a long time, like a thyroid cancer that's well differentiated, or something like a prostate cancer this is common with, or even some breast cancers. And then eventually there's growth in late stage metastatic progression. So we've been interested in each of these components. We've been most interested in my lab in understanding the inflection point that occurs at the time of this late stage metastatic progression. But let's focus first here at the early stages of thyroid cancer development and see what's known. So there are many, many studies that have looked at the genomics of thyroid cancer. This is one that I think sets a really nice baseline. I was lucky to be involved in the science and the writing committee for the TCGA, which stands for the Cancer Genome Atlas. They applied this to papillary thyroid cancer. So these were, just to set this as a baseline, primary thyroid cancers, all well differentiated, all papillary thyroid cancers. They were almost all early stage tumors. The samples were from the central part of the tumor, which is important because we and others have published changes across tumors as you get to the invasive front. So these are from the central part of the tumor, so probably the quietest parts of the tumors. No follicular cancer, no poorly differentiated cancers, and only 11 patients had distant metastases. So this is sort of a nice baseline for papillary thyroid cancer, kind of garden variety, what you see that generally is associated with a good prognosis. So here is just one slide. There will not be a quiz tomorrow on this, I promise you, but I just want to highlight a few things. So we first set up on the gene expression panel something that we call the BRS, a BRAF or RAS score. So the genomes were so quiet in these that we could actually separate these two oncogenes very nicely. So you can see in the green here, these are the tumors with a BRAF mutation. They had a high BRAF RAS score. We set it up that way, so that's not surprising. But as you work your way down this slide, I think you can see that all this blue on the left, whereas you have red on the right. So this is mRNA clusters, microRNA, DNA methylation, RPPA is protein expression, the types of histologies, like I mentioned earlier, all seem to go along with the presence of particular mutations. Then we had a RAS-like group, and these in the green here that are shown that were circled in the red are the RAS mutations. In thyroid cancer, it's almost always NRAS, very similar to melanoma. And you can say that they also clustered all the way down. If you look down to the bottom, all the red seem to cluster there. Then there was a group in the middle that seemed to kind of be in this sort of gray zone area. These are fusions that were identified in something called in PPAR gamma and NTRK, like you find in many other kinds of cancers. And they were kind of in between. They had some signaling that seemed to go along with BRAF, a little bit like RAS. And then we identified a couple of new rearrangements in a number of genes in this particular project. And this was about 500 papillary thyroid cancers. So that kind of is the baseline of what you see in papillary thyroid cancer. So do these driver events mean anything on their own? And I can tell you in a word, the answer is going to be pretty much no. If you look at large population studies, BRAF V600E mutated tumors are associated with more aggressive behaviors, but you need thousands of patients to be able to get a p-value. And most of the studies on multivariable analysis, if you compare it to clinical staging, it does not maintain statistical significance. However, BRAF V600E mutant tumors are enriched in clinical trial populations, and we published the first phase 2 study using sorafenib, and they were 85% had BRAF mutations, and they were not selected for that at the beginning. So clearly some BRAF tumors are more aggressive than others, but BRAF alone is probably not enough to predict aggressive behavior. NRAS tumors are more frequently have distant metastases, but these also occur in follicular thyroid cancer, which we know more frequently as distant metastases. So this was not a surprising finding. Importantly, these mutations also can occur in benign tumors, so they are not diagnostic of thyroid cancer as compared to BRAF V600E, which is almost always only found in papillary thyroid cancer. So if BRAF V600E is not enough, then it must be BRAF plus, because we have this enrichment in the clinical trial populations. And one of the modifier mutations that's clearly a modifier are mutations in the promoter to TERT. So what is TERT? TERT is actually the gene that encodes the telomerase activity, the active component of the telomerase molecule. And so these are mutations that, when they occur, increase the gene expression of telomerase. And what telomerase is the biological clock for cells. So telomeres are at the ends of chromosomes. They get added on. And when there's a lot of telomerase activity, you continue to maintain telomere length, and that then enables cells to continue to live longer, and then they gain more mutations. And what was shown by mostly Mingzhao Zheng's laboratory, that MAPK activation, whether through a BRAF mutation or a RAS mutation, can further accelerate the TERT expression levels and therefore lead to a synergistic cooperative relationship. And in fact, it's the BRAF with TERT promoter or RAS with TERT promoter that appeared to be a little bit more aggressive than without. I mentioned Hercule cell cancer. For those in the field, we've all grew up being taught that Hercule cell cancer is a variant of follicular thyroid cancer. However, over the past 3 to 4 years, it's clearly been demonstrated that they are genomically unique. They will and now do have a separate classification. They're no longer considered a variant. They're really interesting. They've got a lot of mitochondrial gene mutations, but what's really cool about these is that they have widespread chromosomal loss. There are a couple of chromosomes that are maintained, but they're haploid for most of their genome, and no one really understands exactly why yet, but we and others are working hard in this particular area. Okay, so I told you that kind of sets the baseline, but what we're really interested is in determining targets to help us treat patients with more aggressive disease. So now we're going to be talking about patients that are sitting in this area, that already have had invasion, they have distant metastases, and they're either still in dormancy or they've escaped from dormancy. So let's define the population that we're talking about when we're thinking about using a therapy that's beyond radioactive iodine. So these are really utilized in patients with progressive distant metastases, or those with high volume disease and symptoms due to the metastases. So larger volume disease, growing larger volume disease, distant or locally invasive that's already failed surgery, radioiodine, and in many cases, external radiation therapy, dependent on the site of the metastatic lesion. It is not for patients with stable or very slowly growing low volume distant or local regional disease, because as I mentioned, metastatic dormancy is very, very common in thyroid cancer. So this again is not something you need to memorize, but in red, what I have listed are those therapies that are FDA approved specifically for well-differentiated progressive thyroid cancer. That's cabozantinib, lenvatinib, sorafenib, vandetanib. And then in red, but not underlined, is dabrafenib and trametinib that's now FDA approved for anaplastic thyroid cancer that has a BRAF V600E mutation. So what I want you to focus on is that some of these are quite specific, like vemurafenib and dabrafenib, that are only active against BRAF V600E. And most of these are what we would call multi-kinase inhibitors. You should think of these as anti-angiogenic agents. They're approved for many other cancers, and thyroid being one of them. And I'll show you the data to support that from a couple of the critical articles. When you're thinking about more targeted approaches, this is from a recent review article that I published looking at other things that have been looked at and or could be targeted. So checkpoint inhibitors, like many cancers, those that have microsatellite instability or high degrees of genomic instability, and probably also high PD-L1 expression are tumors to think about for immune checkpoint inhibitors. There are FDA approvals for those that are disease agnostic. So if you've got the biomarker, you can get them. These are some of the receptors that are either mutated or overexpressed, and in this case, rearranged in a fusion frequently in thyroid cancer. There are other tyrosine kinase receptor fusions that are intracellular, like NTRK, ALK, and some of the rearrangements involving RET, so-called RET-PTC fusions. And then there are mutations, as I mentioned, in BRAF and RAS, and less easily targetable mutations in PI3 kinase, as well as the AKT1 plextrin homology domain. So these are the targets that we think about for thyroid cancer based on what we know from preclinical models in cells and in mice, and what we also know from clinical trials and clinical research that I'll share with you as we move forward. So the first FDA-approved drug for progressive metastatic differentiated thyroid cancer is sorafenib. I mentioned earlier that our center, Manisha Shah and myself, led the first phase 2 study with sorafenib. This is Marsha Brose's study, which was the phase 3 study published in The Lancet now in 2014. And you can see that the right side is the best tumor response, showing a fairly high, 70% or so of people with some degree of either minor response up to 30% or true partial response greater than 30% compared to placebo. But if you look at these curves, and these are progression-free survival curves, you can see that while there is some improvement with the sorafenib, the slope isn't all that different. You can see that the progression-free survival increased from 5.8 to 10.8 months. And I want you to focus a little bit here on the placebo group, because you can see this was an early study, and you can see that not all the patients were progressing particularly rapidly that were enrolled in this study. And we learned in doing these studies that we probably need to be doing these in patients with a little bit more aggressive disease. And you'll see that in the next slide, which is a lenvatinib study. So this is now a couple years later, published in about a year later, published in 2015. This is the phase 3 study. Martin Schlumberger was the first author, published in New England Journal. And you can see first off that the placebo group, if you compare it to the prior slide, here's this placebo group, and here's this one. Now, it's not the same study, but you can see that these patients had more progressive disease. The inclusion criteria was a little bit different, and it required more evidence of rapid progression for enrollment. And you can see that in this case, when you look at these patients who are sicker, lenvatinib clearly changes the slope. You can see an improvement from 3.6 months in the placebo group of progression-free survival to 18.3 months. And in a certain subpopulation, some older patients in particular, and some mutations, you can actually find a difference in survivorship, although this was a crossover design and the numbers get fairly small. So most of us are using lenvatinib as the first line therapy in patients with metastatic progressive thyroid cancer that don't have a definable mutation to target over sorafenib because of these comparative data, but recognize this is not a head-to-head study, and many patients will end up on one or the other over the course of time. So what about patients that have a BRAF mutation, especially BRAF V600E, which is the most common? Well, there are a number of drugs that have been developed to target BRAF V600E. They don't target activated wild-type BRAF because BRAF V600E signals as a monomer, which is required for the binding of the drug to the kinase. And this is one of the first studies, again, from Marsha Brose in Lancet Oncology, looking at BRAF inhibitors alone as a monotherapy, showing objective responses in a substantial minority of patients. These are change in tumor size of 30%, so the classic RECIST criteria. And you can see a number of patients also had what we would call, again, a minor response in comparison to baseline. And here's some images from a similar study, in this case, anaplastic thyroid cancer, where you have a PET positive tumor here that clearly responds to the drug. And then you see you sort of escapes here over time. A lot of excitement about this when these first studies first came out. We just published, presented and now submitted for review a study, which is a prospective randomized study of comparing dabrafenib alone, which is a BRAF V600E inhibitor, versus dabrafenib plus trametinib. This is similar to the studies done in melanoma that showed the combination was more effective. You can see that most patients in both groups on the waterfall plot had a very nice response, either minor response or a partial response, including some some complete remissions. But I think you can see here that there's really no difference between the monotherapy and the combination therapy. And that, again, is different from melanoma. So based on this study, we have typically been using dabrafenib monotherapy rather than combination therapy, unless a patient has progressed on dabrafenib. There's some data I'm not showing you yet that when we converted patients, when they moved over in the crossover to combination, a number of them responded. And also some patients on dabrafenib alone can get RAS-driven skin cancers and skin tumors that can be blocked when you add trametinib to the combination. So some patients end up on combination for medical reasons. I mentioned anaplastic thyroid cancer. So this is a retrospective study of a small number of patients that led to FDA approval of BRAF, a combination dabrafenib and trametinib in anaplastic thyroid cancer. There's no head-to-head comparison study for this particular disease. This is from the group at MD Anderson, Maria Cabanillas's group. And you can see that the majority of patients with anaplastic thyroid cancer had a partial response, and there was one even complete response. And you can see the duration in this earlier study was pretty high. Obviously, this is not randomized, not prospective data, but with the very, very poor outcomes anticipated from anaplastic thyroid cancer, this was FDA approved on this basis. And it's now considered the standard of care to do a rapid evaluation of an anaplastic thyroid cancer for a BRAF V600E mutation so that you can put them on this therapy right away. We are currently have a clinical trial ongoing, a phase 1 study, looking at combination of this plus external radiation, doing a dose response evaluation based on a really strong preclinical data from my collaborator, Terry Williams, who's now out at City of Hope out in California. The group down just published just last month an update on this population with a longer duration of follow-up. I thought this was instructive to see again these responses. Again, a couple of complete responses here. And you can see that the best responses here, this is the treatment duration, and this is really important in anaplastic thyroid cancer, where many patients are maintained on therapy, and this is weeks, but you're looking at 150, 160 weeks. This is unheard of in anaplastic thyroid cancer to have patients with surgically unresectable disease living years. So this is really a useful therapy. But importantly, there are some patients that don't respond and don't respond at all. So you can see, again, weeks on study, proportion of patients alive and progression free. You can see really starts to drop after a year. You're at about 50%. And the survivorship curves mirror this particular plot in this paper. So definitely an advance, but not curative. So that then leads us to why isn't it curative? What could be the causes of resistance? And a number of groups have been working on this, including ours. First off, it's nearly universal, regardless of therapy, that whether it's a multi-kinase inhibitor or a targeted inhibitor. For BRAF V600E, I'll focus on that. Acquired KRAS mutations were originally described by Marie-Claude Hoffman and her group at MD Anderson, where they're close collaborators of ours. And a number of other groups have shown these as well. And they acquire EMT via c-Met and as well as some other signaling pathways. And then I'll show you some data for a new mechanism that we've recently uncovered with Marie-Claude that we just published about a month ago. So this is a patient this is their pretreatment biopsy with a really, in this case, it was a tall cell variant of PTC with a BRAF V600E mutation. They started on a different BRAF mutation, I'm sorry, a BRAF indel. And post-treatment, they started to have progression. And you can see the change in the tumor to a more, not quite anaplastic, but certainly not a not a papillary architecture. And then we took this tumor and we put it into mice with PDX. We made a PDX, a patient-derived xenograft out of it, and grew this out in mice and then grew them out in culture. We did a lot of genomic screening on this resistant tumor in B versus the primary, and then compared it also to the mouse xenograft and identified an unexpected mutation in a gene called RAC1. This RAC1 gene with a different mutation than what we identified is a cause of resistance to BRAF inhibitors in melanoma. So, but those are primary. This would be a secondary mutation. And we showed here, without going into all the detail, that the PDX model is in fact resistant to dabrafenib therapy in comparison to the other tumor, and that it does respond to what EHOP16, which is a RAC1 inhibitor. So it's functionally active. We showed as well that it changes the architecture of the cell, both in 2D and in 3D model systems, and it increases growth only in the 3D model system. And then this is where things got really interesting. So one of the chromosomes that's always retained in Hercule cell thyroid cancer is chromosome 7. We noticed in some of the early studies that we did that RAC1, in addition to being mutated, was highly overexpressed. Did a number of studies and showed that it's not only highly overexpressed at the RNA level, but there are many, many copies of it at the DNA level. So it turns out there's gene amplification of most, if not all, of chromosome 7. So not only is RAC1 mutated, it's overexpressed. In addition, a number of cancer genes like TWIST1, the EGF receptor, MET, and BRAF itself are all overexpressed in this model system. So there is a very interesting mechanism of action, and we're looking now to see whether this chromosome 7 amplification is common in thyroid cancer resistance now. So another use of BRAF inhibitors or RAS inhibitors is what's called redifferentiation. So I want to talk about this for a moment. So I mentioned that we saw that we had that BRAF RAS score. We also created what's called the thyroid differentiation index and noted that the higher the BRAF RAS score, the more signaling through MAP kinase, the lower the differentiation score. And this is known a little bit. We kind of identified it as part of this study. And then a number of groups worked to see whether if you take a model where you have a receptor that's mutated or a BRAF mutation or a MEK mutation, where you have this reduction in the sodium iodide symporter and a reduction in iodine uptake, if you target those and disrupt it, can you now increase the sodium iodide symporter and increase iodine uptake? The long and short of it is that in preclinical models, the answer is yes, and that's true in cells and it's true in mice. The question is, what about in people? So Alan Ho and Jim Fagan at Memorial Sloan Kettering did a clinical trial published in 2013 in New England Journal, where they took patients who had radioiodine refractory thyroid cancer. So the cancers I mentioned that were growing after radioiodine therapy that had a BRAF or a RAS mutation where this would be really active, did an I-124 PET CT. You could also do I-123 scans, treated with the MEK inhibitor selumetinib, and then redid the iodine scan. If there was a big response, then they went ahead and treated on the selumetinib. If there was not, then they stopped the selumetinib. And you can see that they had a number of cancers, about half the BRAF mutated tumors, all of the NRAS mutated tumors, and some of the others had an increase in iodine uptake with the MEK inhibitor, about 60%. And here's what happened. So here's an example patient that they show. This is baseline before the selumetinib. This is after the selumetinib in this patient. Here is this patient where you have an increase here. This patient where there's a low level and now much higher. And here's low level baseline and higher in the skull met. And you can see what happened, that there was over time evidence for response in a fair number of patients treated with radioiodine. And here's the thyroglobulin levels that they had as well. So this was a lot of excitement about this when this paper came out. This has led now to a large number of clinical trials and use of this in the clinic now. So the general approach, either clinical use or in clinical trials, is if you have a RAS mutation, we tend to put patients, if we're going to treat them, if they've already shown that radioiodine resistance, with trametinib, which is a more potent MEK inhibitor than selumetinib or one of the other MEK inhibitors. If you have a BRAF V600E mutation, people use either a BRAF V600E inhibitor or combination with a MEK inhibitor. RET fusions, there are studies now ongoing with RET inhibitors to increase it. There's data showing that if you have one of these NTRK fusions, you can use an NTRK inhibitor and increase as well. And really exciting is that it's been demonstrated that if you have a BRAF V600E mutation and don't respond, you more frequently have an abnormality either in the SWI/SNF complex or overexpression of HER3, but most times they're linked. So that you can sometimes treat now, and this is just published, a preliminary study just published a few weeks ago, using this combination of the BRAF inhibitor with a HER3 targeted antibody, showing some benefit. So really exciting area. Exactly where it's going to fit into the lexicon of treatments, we're not entirely sure, but we are using it. Okay, so what I want to focus on now as we come to the last part of the talk is what's going on out here. What's going on to cause this late stage growth? And this is actually what most of my lab is focused on, is why is there this inflection point that occurs? So one, it could be related to the tumor immune response. Pembrolizumab and nivolumab, we know cause thyroiditis and hypophysitis, so we know you can induce immune response against thyroid cells. There are now a couple of published studies, I'll show you one, using monotherapy PD-1 or PD-L1 inhibitors in thyroid cancers that either have evidence of genomic instability, MSI, so mismatch repair abnormalities, or have overexpression of PD-L1. And here's just one of the early studies from 2018. This was not a randomized study, but it shows partial responses in a number of patients who either were on or not on another targeted or multi-kinase inhibitor. There was not a huge correlation in this study with PD-L1 expression levels, but there's a positive study now in anaplastic thyroid cancer with a PD-1 inhibitor, and another study that is being completed using lenvatinib plus pembrolizumab in anaplastic thyroid cancer that's pending review now. So we've been interested in understanding what's happening at the distant MET site. So we did a small study a few years ago where we have both primary tumor and distant METs from a group of patients and analyze them genomically. It's a relatively small study. These are hard samples to come by. It was 19 samples from 11 patients. All had prior radioiodine between their primary tumor and their distant METs resection. So these are post-therapy. This is kind of what we see in the clinic. No patients were on kinase inhibitors. There were 2 patients with anaplastic thyroid cancer. And yes, this was a collaboration with University of Michigan. So OSU and Michigan can successfully collaborate, maybe not on the football field. We did a custom 682 next generation panel. And we also did mirror sequencing on all the samples. And here's the long and short of it. This demonstrates that what we did see in the distant MET site almost exclusively was the combination of ATM and ERCC4 mutations in the tumors that mostly did not have RAS or BRAF mutations. And I'll explain why that's important in a moment. We thought that was very exciting because these recurrent mutations have been described in other tumors that have evidence of resistance to therapies. ATM is a tumor suppressor gene involved in DNA damage repair and telomere stability. ATM stands for ataxia telangiectasia, if you don't remember. These are the variants that we saw. ERCC4 causes Fanconi anemia and xeroderma pigmentosa. It's also a tumor suppressor that's also involved in DNA repair, in this case, nucleoside excision repair. And we also found variants in this, and they occurred together, and they were mutually exclusive, as I mentioned. So why is this interesting? Well, it might suggest because these two proteins actually work together in DNA repair and have been shown to, when they're both abnormal, to predict sensitivity to ATR kinase inhibitors. So we're now currently doing preclinical studies using ATR kinase inhibitors in these patients. We are uncertain whether these were induced by radioiodine or did they just occur over time, over the course of the lifetime of the tumor. So what else could be going on at a metastatic site? So we talked about new drivers. Most times the drivers are not new. They are consistent between the primary tumor and the distant metastases. So when you're genomically analyzing a tumor, it's generally okay to go back to the primary tumor, even if it's old, to look for the original driver. We talked about some changes like we saw in ATM, but there's another possibility. So thyroid cancer, as I mentioned, tends to stay dormant for long periods of time. A group of genes that are called metastasis suppressors or metastasis progression suppressors were identified many years ago. There are about 25 to 30 of them. So we were interested whether there could be, instead of a new accelerator that occurs, maybe there's loss of a brake. And in fact, we've identified one that we've published a bunch with now. So I'll show you a brief bit on some preclinical data. This is a gene called ARCAN14, which is known as a regulator of calcineurin. That's what ARCAN stands for. And it also has another name, as a Down syndrome critical region 1 gene. And just to cut to the chase, these are mice with primary tumors. These are nude mice that are injected with thyroid cancer cells, human thyroid cancer cells, that either have just a control shRNA, or we've knocked out ARCAN14. And you can see that the tumors are larger over time. If you knock out ARCAN14, these are two different thyroid cancer cell lines of two different genotypes. And you can see the sizes here of what we resected. And these are the changes in the tumor size over time. And this is now looking at things like Ki67, which is growth, caspase-3, which is looking at apoptosis. What really got us excited about this was this slide, which shows that when you do a tail vein injection, or if you put them in the flank, if you look at the controls, they don't metastasize to distant sites, except maybe a touch here in this one. But almost all of the mice that have ARCAN14 knocked out develop distant metastases. You can see these are the measurements of what I'm showing you here. And this is the histology showing the distant metastases in one cell line and another. So this would define that this is actually functioning as a metastasis suppressor. And it's functioning through a gene known as NRF3. And NRF3, which I don't have a chance to show you all of the preclinical data, but the NRF family of transcription factors are one of the 26 upregulated genes in cancer identified across all cancers in the TCGA. This is the first linkage of this to metastasis and the first linkage of it to ARCAN1. This is papillary thyroid cancer in normal in the TCGA, so it's higher in the PTC than normal. And this is now looking at our own samples over the course of metastasis, showing that it goes up in the tumor and it goes up in the invasive fronts and stays up in the metastasis. And here are some of the immunostainings for NRF3. So this is one of our NIH grants where we're trying to understand how ARCAN14 is downregulated, where you have a paper that's been submitted now showing it's methylated, and how NRF3 is functioning. So we're just about to the end, so we can get to some questions. So how do we put all this together? And I'll share a case with you right after this slide to give you an example. So first is we need to determine if a patient truly is radioactive iodine resistant. Now, this might be changing because it may be that to really determine that someone's radioiodine resistant, we may need to try of a redifferentiation therapy depending on their mutation status, but that is not really clear yet. So if you have a patient then who has radioiodine resistance and has progressive metastatic disease, we typically would then evaluate their tumor genomically, generally not with just a targeted BRAF or RAS screen anymore, but with something more global because of all these other therapies that have been FDA approved regardless of what type of tumor it is, that are based on the genomic change. So it may be that you're going to find a mutation that has a specific thyroid cancer indication with the FDA, like say an anaplastic thyroid cancer with BRAF V600E, or a medullary cancer with a RET mutation, or a papillary cancer with a RET fusion. So these are approved for thyroid cancer specifically that has these genomic abnormalities. It may be that you'll find a mutation or rearrangement or a fusion that has an FDA approval, not specifically for thyroid cancer, but for any tumor that has that particular change, like TRK inhibitors, larotrectinib and entrectinib, which we sometimes can find. It also may be that there will be some kind of biomarker to suggest they might be one that would respond well to immunotherapy. So that's why you would do the genomic testing. It also frequently will happen that you don't have a targetable mutation. And if you don't, you have the options clearly of a clinical trial, or you can put them on one of the FDA approved multi-kinase inhibitors that's FDA approved for progressive thyroid cancer, independent of driver oncogene. And generally, we're using lenvatinib as a first choice and sorafenib as a second choice. So let me close with a patient, and this is a real patient that I just saw last week. No, actually, I just saw Tuesday in clinic, so this week. He was diagnosed with thyroid cancer at age 71. Really interesting guy. He's a race car driver and was still racing at the time that he was diagnosed. In fact, this was now 10, I don't remember how many years ago, about over 10 years, I'm sorry, 13 years ago. He just stopped racing 2 years ago. So the tumor was 9.2 centimeters in the left lobe. It was a papillary cancer, extrathyroidal extension into the recurrent laryngeal nerve. So he had his nerve was out. He had a hoarse voice of presentation. This should be wall. So it was invasive into the tracheal wall. 4 of 36 positive lymph nodes. They got clean margins. They were able to sort of scrape it off and had a lot of fibrosis. Chest CT had innumerable small lung nodules. He was treated with radioactive iodine, had no uptake in the neck or chest with a thyroglobulin of 446. So with 8 millimeter nodules and that high of a thyroglobulin, probably radioactive iodine resistant, or at least not very avid. And this would be a stage 4C, T4, N1B, M1 papillary thyroid cancer. So remember, I'm talking here about 2008. He stays stable for almost 3 or 4 years. So thyroglobulin on TSH suppression therapy starts to go up. Neck nodes do start to grow a little bit. The lung nodules are also growing. He gets referred at that point. We want to make sure he doesn't have brain mets. His brain MRI is negative. We get a PET CT because it's pretty a little more aggressive and iodine negative, and it was positive on PET CT just in the neck and lungs, fairly low down in the neck, and asymptomatic. We did a whole body scan just to make sure, because now the thyroglobulin is higher and the lesions are larger, and that was negative. He did develop in 2016 a new bone metastases in the thoracic spine that was treated with external beam. Now we're 8 years now after presentation with stage 4C disease. So the tumor continues to grow. He has an accessible neck mass, which I biopsied. He had a genomic screen, which identified a BRAF V600E mutation, an hTERT promoter mutation, and loss of P53. All of these are associated when in combination with his clinical course, which is more aggressive. Because of the BRAF mutation and because of those early data, we started him on venurafenib. Manisha Shah did this with me in medical oncology. He had a dramatic response. And when I say dramatic, he had a 4 or 5 centimeter neck mass that shrunk to non-palpable in the course of 3 to 4 weeks. And on CT had a 90% reduction in tumor volume overall. It stayed that way for 2 years. He's had to lower the dose due to side effects and has had a little bit of growth, but nowhere near where he was then, and he continues on this therapy. We have approached him, and I discussed doing radioiodine scanning on him again to determine if he might be appropriate for another radioiodine therapy. He does not want it. He's 84 and is not interested in going on a low iodine diet. Now, unfortunately, one of the side effects of the BRAF inhibitors can be pulmonary hypertension, and he now has evidence of this on his recent CT scan done just a few weeks ago. So we may need to revisit this attempt at redifferentiation. So to summarize, for selected patients with life-threatening metastatic or poorly differentiated thyroid cancer, these are the patients that have failed radioiodine therapy. These are the patients to think about these kinase inhibitors or clinical trials were appropriate. We're doing lots of studies right now trying to optimize these therapies or come up with second-line therapies, but we've made major advances, I think, over the last 10 years or so in this regard. And a lot of this has been driven by genomics that have identified new pathways and new targets, and also new drug development. So we think an understanding of the functional genomics is critical to improve patients, not just with metastatic thyroid cancer, but with other metastatic progressive cancers. And that really what we want to do is see whether we can move up the therapy earlier if side effects are reasonable. I think it's hard to cure patients when they have large volume progressive disease. It might be easier when the volume is smaller and the tumors are a little more simple genomically if we can identify them more accurately earlier. So this is my lab. I want to thank them, my funding that has supported some of the work I showed, and my long list of collaborators as well. So we'll close up and I will stop sharing and be open for questions.
Thank you. Dr. Celli?
Yes, Matt, thank you so much for this beautiful talk. And again, what I love about your presentation is that there are very esoteric bench-based data that then go straight to the bench side, from the bench to the bedside. And again, I think that differentiated thyroid cancer is a great model of personalized medicine. What I'd like to ask you, and I'm also following on Dr. Gardner's question in the chat line, is can you elaborate again on when to pull the trigger for treatment? And my personal take is that, as you know very well, and probably the audience doesn't, most of the tyrosine kinase inhibitor treatments for thyroid cancer are initiated in the community. And if you want to elaborate a bit further there.
Yeah, so it's a really good question and a really important one. And I didn't go into the side effects of these drugs in great detail, but I was remiss in that. So these multi-kinase inhibitors, lenvatinib, sorafenib in particular, and the medical oncologists on this will agree, I'm sure, definitely have side effects. This is not like taking thyroid hormone. It's not cisplatin, it's not adriamycin, but and they are pills, but patients rarely are able to be maintained on full dose due to hypertension, QT prolongation, diarrhea, fatigue, rashes, etc. And there's about a 1% death rate from these drugs as well, so you really need to be careful. Most of that is due to fistula formation as well, which can be an issue in thyroid cancer if they've had reconstructive surgeries and things in their trachea and esophagus. So patients' quality of life will be affected by these drugs, okay? More so for those multi-kinase inhibitors, a little less so for the more targeted drugs. So that balanced against the fact that many patients will live sometimes for decades and decades with stable, small lung metastases, for example, is why we don't put people on these drugs that have distant metastases with high thyroglobulins that's not changing. We really try to follow patients with TSH suppression therapy. I have patients who are 30, 40 years into lung metastases without any progression at all, and watch them because eventually they will get to that inflection point of growth. And that's the point where we really try to start patients on, when their growth rates really increase. So how do you judge that? You can look at doubling times of thyroglobulin, which has been shown if it's less than 6 months, or certainly less than 2 years, they're much more likely to progress more rapidly, especially if the thyroglobulin is over 50 to 100. You can do doubling times as well on CT scans also. So this is not something that every patient with metastatic disease needs to go on. This is for patients that have progressive metastatic disease or disease in bad locations. Sometimes we do it. Let me go into the Q&A and check here. Okay.
Right now, no other question. Can I, as questions are percolating or
Sure.
just to close, can I ask you to elaborate on the concept of geriatric disease versus not? In other words, we tend to use age as a differentiating factor when whether treating or not. And here I'm talking anecdotally, I'm sorry, and let me close the distraction. And I'm talking anecdotally, I have quite a cohort of patients with advanced thyroid cancer and advanced age. And to me, the decision inflection point is whether the patient is doing okay. It's really not age.
Yeah, and I think that that's a great question, and obviously that's the clinical, one of those clinical things, right? You need to always balance the risk and the benefit of every therapy, and of course, patient wishes. I mentioned that in the patient I presented, who for whatever reason does not want radioiodine scanning even again. So I think these are very individual decisions. I think there are some people who have a lot of comorbidities that are young that can't tolerate things. There are people who are older that can tolerate things. So I think these are shared decision making with patients and their families about what they would like to do. They need to understand that these are not curative, but they do extend life and improve progression-free survival. I would say that the more targeted therapies in general are pretty well tolerated, other than people that have very specific contraindications for it. But lenvatinib and sorafenib can be more difficult. Sometimes we modify the dose and start patients on lower doses, and we come up with some dosing strategies, and those can be done. But again, these are all individual art of medicine rather than kind of decisions that you have to make with individual patients.
Great. I think we heard a lot, and it's been a true masterclass. And again, thank you for coming. And this is a down payment. We really want to see you here in person.
I'd love to get down to Richmond again to see you guys. So
yeah, I'll come down.
Yeah. Thanks so much. It's been a pleasure.
Bye, Matt. Thank you so much.
Care. Okay. Bye-bye.
Thank you, everybody. That's the end of our Department of Internal Medicine Grand Rounds. Thank you, Dr. Ringel. Thank you, Dr. Celli, for facilitating. Appreciate it. Everybody have a great afternoon.
Bye-bye.
Bye.